morning, good afternoon, good evening to every one of you. It's a pleasure to see that over 170 of you have joined this great webinar, and you are very welcome to share your name and where you are calling in from in the chat, just as Bruna just said. It is a huge privilege for us at the International Confederation of Midwives, at FIGO and WHO HRP to welcome you to this webinar, which will share some insights from a collaborative project that we are working on that we hope will support and encourage many of you. This collaboration between ICM, FIGO, and with the support from WHO HRP is focusing on interprofessional collaboration. Many of you who work with midwives, with doctors, obstetricians, and gynecologists know the importance of working together for the best of women and their newborns. In this project, we are utilizing a gender transformative approach on how we can increase access to services for women and for girls. And we are also working very hard how we can foster this interprofessional collaboration between midwives and obstetricians and gynecologists. In this program, we are focusing on 5 countries: Nepal, Bangladesh, the Democratic Republic of Congo, DRC, Sierra Leone, and Mozambique. And we are immensely grateful to the midwifery and obstetrician and gynecology associations who are involved, and to all the midwives and doctors who have been involved thus far and will be involved in much more looking forward. We are really, really happy to have you here. So after these words from me, I'm Anna Foglas. I'm the Chief Executive for International Confederation of Midwives. I want to give back the word to you, Bruna, and welcome you all once again. Thank you.
Hi, I believe it's me that's coming into the conversation now. Thank you for that, Anna. Nice to see you all here. Good morning, good afternoon, good evening. My name is Sab Franklin. I'm a midwife advisor at the ICM. I will be giving you a little bit of background about the initiative that Anna introduced before leading into our speakers. And I will have some help from my esteemed colleague, Vedra Karen at FIGO. So next slide, please, Bruna. So we had a little bit of an opening there from Anna, and the ICM contribution to this program of work includes a few different things. One is focusing on our essential competency for midwife practice, the competency 2, which refers specifically to sexual and reproductive health and rights. And this really is a clarification of the midwife scope of practice concerning the provision of preconception care, family planning, and comprehensive abortion care. We have also, as part of the dissemination of the essential competency 2 and the sensitization of that competency, translated quite a lot of our documents to Portuguese to meet the needs of our fantastic colleagues from Mozambique. And you can see a list of these translated documents in this slide. Next slide, thanks. Another part of this initiative for ICM was holding the International Stakeholders Meeting for Collaborate for Women. That was in Nairobi in the beginning of September. We are fresh back from that event where we all had the most amazing experience of collaborative conversation between women's advocacy groups, obstetricians, gynecologists, midwives, and our implementing partners from the global stage. a lot of focus on lifting women's voices and how we can achieve effective collaboration for increasing access to family planning and comprehensive abortion care services. Next. I think we might have hopped one there, but we can take it quickly. We also are engaging in supporting our 5, if you just go back one slide, Bruna, I think, our 5 focus countries with capacity building workshops focused on rolling out family planning and comprehensive abortion care services provided by midwives. But now I will hand over to Vedrina, who will tell you a little bit more about FIGO's contribution.
Thank you so much, everyone. And thank you to Zab. I will be speaking a bit about FIGO's contribution. As Zab has said, Bruna, I think we may need to go back just one slide, but I can kick us off nonetheless. So our 2 sets of deliverables have been interrelated but slightly different. So FIGO's work has focused on supporting the uptake of a competency-based approach to education in family planning and comprehensive abortion care using the WHO Family Planning and Comprehensive Abortion Care Toolkit for the primary healthcare workforce, which is a best practice document for the skills, attitudes and knowledge needed to deliver FP and CAC services most effectively. The first phase of this project has centred on needs assessments and gap analyses in our 5 project countries. So to facilitate this work, country teams have set up their own respected task forces composed of government representatives, WHO country offices, midwifery associations and other relevant stakeholders. And this group has been crucial in supporting the work of our deliverables in this first phase. The first one of which was conducting a high-level needs assessment detailing how curricula is created at a national level and giving a broad overview of FP and CAC curricular gaps relative to the WHO toolkits. Next slide, please. So the aim of the toolkits, just to touch on them quickly, is really to address the need that family planning and comprehensive abortion care is part of primary healthcare, but it's often poorly provided and missing from training. So the toolkit consists of 3 parts. Volume 1 presents the necessary competencies for high quality family planning and CAC services grounded in the latest evidence and guidelines. Volume 2 is a set of 25 evidence-based practical instruments to help educators, policymakers, and other relevant stakeholders implement a health education system that integrates the competencies described in Volume 1. And Volume 3 is a dissemination, implementation, monitoring, and evaluation guide intended to facilitate accelerating global awareness, uptake, and use of the competencies. Moving to the next deliverables, our country teams developed country-specific roadmaps for short, medium and long-term priorities for curriculum development and strengthening. And my lovely colleague Joanna from Mozambique will talk about this process a bit more later on. National societies are now in the process of conducting a more detailed and in-depth assessment of their chosen priority curricula that will consider how to integrate the breadth of the core competencies. That's all from me. Back to you, Zab.
Okay, thanks, Vedrina. So together, I think the next slide will reveal a little bit of what we're doing together. One of the products of the international meeting in September in Nairobi, or the 2 products, in fact, a collaborative statement, a joint statement between our 2 professional organisations, ICM and FIGO, focus on interprofessional collaboration and what it means and how we do it. And that will be broad enough to cover all aspects of sexual, reproductive, maternal, newborn and adolescent health care. The second statement is a continued collaborative work for the provision of comprehensive abortion care. We also have a joint statement from 2024 on family planning. So we're just tying that package together. At the moment, these statements are in draft form. Next slide, please. So together, these statements and our ongoing conversations are focused on equitable, gender transformative interprofessional collaboration. And to that end, I'd like to assume my position as moderator for the ongoing webinar and briefly introduce our first speaker, Professor Anne Kahara, who is the current president of the Federation of Gynecology and Obstetrics, also a senior lecturer in the Department of Obstetrics and Gynecology at the University of Nairobi, where she has worked for the last 15 years and has many other prestigious titles. But in the interest of preserving time for you, Anne, please go ahead.
Thank you, Zap. And first, I want to acknowledge the support of WHO and this wonderful collaboration between FIGO and ICM. And it can't get any better. But let's talk about today. And first, I want to wish you all a happy World Contraceptive Day. It really has a theme that resonates with all of us. A choice for all, agency, intention, access. Unfortunately, we're dealing with contraception and abortion, two very emotive areas, yet we know it is central for adequate, quality, safe sexual reproductive health and rights. But there are issues, legal restrictions, sociocultural stigma, limited funding sources, and inequitable health systems, which really create major care gaps. And particularly, the further you are financially or by your social determinants, the worse off you tend to be. We also have the added strain that we are beginning to see SRHR pushback. Project 2025, reversal of Roe and Wade, the global gag rule, putting a noose at our necks as health professionals. But I want us to really reflect as a collective. Agency, access, intention, rights. Where is our collective voice and agency? Don't we attend to patients? Don't we see the complications when you do not provide family planning, unplanned pregnancies, risky, unsafe abortions? This should not happen, and particularly in the 21st century. We should be able to give services that are both essential, life-saving, and at the same time, keeping the woman comfortable to be able to return to productivity as well. What are the consequences when we don't do this? And I really like numbers. Every day we lose 800 women, roughly one woman every 2 minutes. It's unacceptable, particularly in LMICs. The mortality is also associated with long-term morbidity, fistulas, infertility, even death, mental consequences. Unmet contraception, 200 million. They want to avoid a pregnancy, but do not have the means to do so. Unsafe abortion, 25 million are happening every year. So when we talk about empowering women to make informed reproductive choice, it becomes a foundational necessity so that even when she does get pregnant, she can get a baby she so desired and the number that she so desired. And when she doesn't want a pregnancy, in the event she does get pregnant, can we give her safe abortion services as part of the essential service that she can access? The return on investment. I like this because contraception is articulated oftenly as a woman's issue. But guess what? For every $1 you spend on a contraceptive, you reap $3. And when you are in LMICs, you reap even close to $4. And when you are a young person, the adolescent and youth, and you do provide them this essential service, you reap close to $4. In terms of the economic productivity, you have a potential for 10% increase in GDP. This is a no-brainer. Contraception is a development agenda. It has implications beyond the immediate health benefit to the woman. The financial burden on the health system is reduced. Pregnancies, childbirth, neonatal care, you get babies that you can actually nurture. So we must think about putting contraception as a necessary tool within the armamentarium. It is life-saving and beyond. Safe and timely performed abortions and post-abortion contraception, again, will amplify health returns, reduce mortality and morbidities from unsafe procedures. For the adolescent, it is a ripple effect in gain. So how do we link these two? We talk family planning or contraception, and we also talk about comprehensive abortion care. Post-abortal, you don't want her to come back again too soon with an unplanned pregnancy. So you kick in her contraceptive care. When I have had my safe motherhood and assume the outcome for the mother and the baby is perfect, again, you want to give the mother time to nurture that neonate. So again, we kick in contraception. It is the integration of the two that reinforces a woman's reproductive autonomy and rights. And as I've belabored, the health burden, even to the health system, declines and pushes us towards universal health coverage. But that's not all. We must begin to think of the conversation of linking contraception and comprehensive abortion care with population demographics and dynamics. Total fertility rate reduction, contraceptive prevalence rate increase, and adolescent birth rates decline, all pushing us towards demographic dividends and giving women the opportunity to be productive to contribute to development. So this is something you must articulate. The second thing is the risk of infertility, the risk of reproductive tract infections, and including reproductive cancers. I often don't hear this conversation, and we must have it. Again, post-abortal, can we begin to have promotion of contraception that even promotes the use of condoms? Because this actually helps the women. And then linking it up to sustainable development goals. I have always said family planning is a development agenda. The same way we say immunization is to children, family planning is to women and girls. It reduces poverty. We're pushing women towards good health and wellness, quality education, because they're deferring getting pregnant and dropping out of schools, gender equality, decent work and economic sustainability, reduction in inequalities. It even has a role in climate action, peace, justice, and strong institutions. And above all, partnerships. And we're starting with this partnership, ICM, FIGO, WHO. We're putting our voice, our collective, not only, as you have been told, in the education piece, but also in the advocacy and accountability to the patients who so deserve this. So we no longer want to have guidelines and guidance and position statements that are autonomous to each of our societies, but rather we want to work together. And what does really working together look like? Because I will not go back to what my colleagues have said. Evidence-based rights. Yes.
I'm so sorry, but in the interest of our other speakers, I'm just going to have to come in there.
Okay.
It's fantastic. I'm very sorry. That's a hard job for a moderator.
No problem.
It's a wonderful speech and start. And I just want to say, you know, you've really framed partnership, collective voice and agency,
yes,
to resist the pushback on women's sexual and reproductive health and rights, and the interplay with women's reproductive autonomy, community health, and economic development countrywide. Fantastic. And please forgive me for interrupting you,
It's
but I'd
okay.
like to offer the mic now to Liliane Nkonge, who is a civil society representative. Liliane is a dedicated sexual reproductive health and rights expert, currently serving as a Deputy Director Technical for the FCDO-funded Wish2 project at International Planned Parenthood Federation in the Africa region. Welcome, Liliane. You've got about 5 minutes. I'm going to have to be very strict, and please forgive me for that. Go ahead.
All right. Hello, everyone, and thank you to FIGO, ICM, and partners for bringing this forum together. And as we celebrate the World Contraception Day, I will share how IPPF is upholding sexual and reproductive health and rights by centering women's voices and some of the lessons that we've learned. I will try to be brief so that manage the time. Next slide, please. So as we all know, IPPF is a global healthcare provider. We are known for the advocacy more, but our teams on the ground are known for delivering care more. So we have pioneered family planning, or rather contraception, in many countries in the world, and we continue to do this work even in the most difficult settings like Sudan and Gaza and other areas. Next slide. So when we look at person-centered care from IPPF, we recognize the role of the provider, okay? So we look at it from client rights perspective and also the pivotal role of the provider that the previous speakers have spoken to. And it's all about voice, choice, access, what Professor has already spoken about. Next slide. And I would like to challenge us when I go to the field. Often the client rights charter is somewhere in the background. Can you bring it to the front, please, so that it reminds us a little bit more? So what do women want? They want their rights right now without delay. And so in the era of misinformation and control that we are seeing, they want that accurate information that is up to date. They want to be able to access healthcare without suffering, barriers. They want choice. Professor has spoken about that a lot. The human dignity in care, safety, privacy, confidentiality as well. In the context of the interprofessional collaboration, continuity of care, comprehensiveness, that is what clients are looking for. They don't know the differences between professions. What they know is the care they want. And then they want us to listen to their opinion and put it into consideration. Next slide. So how is IPPF? So before that, I want to highlight two challenges, and Professor has spoken to the stereotypes and the norms that hold women back, especially around SRH and gender. They are living with us and they are a significant barrier, as well as the role of power. And Professor has spoken to that a bit as well. So can we shift from professional power to empowering our clients to own their own health? Can we challenge provider hierarchies that limit referral, comprehensiveness of care? I think those are some of the areas that we are really making huge investment in, and we can move to the next slide. So how is IPPF expanding person-centered quality care to more women, more people, in more places? These are some of the few approaches I could highlight from our Come Together Strategy 2028 that is available online, expanding choice, including infertility care, abortion care as well, widening access, especially in and humanitarian areas, and advancing digital and self-care. And I'll give a few examples. Next slide. An example from Sudan, where from the feedback we got from mothers and women around the difficulties accessing health facilities during conflicts and also the danger of SGBV, our member association, SFPA, developed the first ever mobile telemedicine clinic. And here women are able to get high-speed video consultations with specialists in Sudan and beyond. Gender-based violence care is also offered there. Digital integrated referral system is there. 9 8 million women were served last year. And that is expanding from River Nile to other 15 states. We can go to the next. So how the voice of the woman is changing how we deliver care. We're also addressing the stereotypes and social norms, and our award-winning digital campaign, Common Senses, has really changed the narrative in the countries of Nigeria, Mozambique, Ivory Coast, and including even other non-target countries like Kenya. We were on it. So it is amplifying the voices of women, putting it in woman-centered way, narratives that resonate with communities. And what we've learned from the next slide, what we've learned is that when we center care on women, the care that we deliver is right-based, affirming her dignity and autonomy. We're able to deliver very comprehensive care that meets diverse needs, including fertility. We're also able to offer care that is transformative, not only the safe birth. We are able to look at the entire ecosystem and how we support healthy choices, freedoms, and all that. Lastly, what we've learned from the narratives, next slide, last slide. What we've learned from the Common Senses narrative is that audiences are interested in CSC. We hear the opposite. So they're asking for more in different formats, and we are working to expand the Common Senses platform. And also what we are realizing is that value-based framing is acceptable when we emphasize rights, autonomy, our humanity, it resonates with people. And then lastly, the role of influencers. The opposition have perfected the art of using influencers for misinformation. It also worked for us on the positive narratives. And this is something we can borrow and apply across the world. And thank you. That is it from me.
Thank you, Liliane. You know, I love it. Shift from professional power to client power. It says it all. The use of technology, implementing self-care or access to self-care, and this leading to increased access to services, choice, dignity, continuity. Thank you so much. Now I'd like to hand over the mic to one of our 5 focus countries, Mozambique, where I am going to welcome Dr. Joanna Chirana, an obstetrician gynecologist representing the FIGO Society of Mozambique and very much involved in the Collaborate for Women initiative. Welcome, Joanna. You have 5 minutes. Lovely to see you.
Oi, boa tarde. Good afternoon, everyone. I will speak in Portuguese, my maternal language. Ok, eu vou falar rapidamente daquilo que é a implementação do projeto de fortalecimento das competências dos provedores de saúde nos conteúdos de acompanhamento familiar e cuidados comprensivos de aborto em Moçambique. Como nós sabemos, o Moçambique já implementa os programas de planeamento familiar e cuidados comprensivos de aborto. Existem fortes oportunidades para esta implementação, porque os planeamento familiar e cuidados comprensivos de aborto são oferecidos nas mesmas salas. Esta integração facilita. A abordagem desta implementação é baseada em direitos humanos, quer para o aborto, assim como para o planeamento familiar. Ao nível programático, como país, estratégias para melhoria, uma das grandes estratégias para melhoria é a atualização de currículo, quer do planeamento familiar ou do cuidados, cuidados comprensivos do aborto, quer assim os documentos estratégicos do Ministério já prevê esta atividade. Ainda mais a implementação do nosso programa aqui no país, uma vez que já está previsto.
Joanna, I'm sorry to interrupt you. I gave it about 1 minute to see if it would resolve itself, but we just have to make sure the translation is working.
Vejo que a Zap está a ouvir.
Sorry. Can I jump in?
Yes,
Rita,
go for
can
it.
we ask Rita, our interpreter in Portuguese, to switch to the English channel and interpreter in English in the English channel, please? Yes.
Alô? Oi, Bruna?
Joana, pode prosseguir. Desculpa, obrigada.
Algum problema comigo?
Não, Joana, pode prosseguir.
While they're sorting it out, Joanna, I'll just let you know that when we get the I'm not sure. Joanna, can you hear me? So, Joanna, you can proceed or go. Joanna, you can keep going now, please.
Okay. Thank you.
I think what you should do is just go back to the start. We will allow time to catch up with the technical difficulties. So you take a big breath and start from the beginning. Thank you.
Hello? Posso continuar? Posso continuar? Ok. Então, dizia que ao nível de Moçambique, os documentos estratégicos
The strategic documents for family planning in Mozambique
a revisão
already
curricular
foresee
e
all
revisão
the
desses conteúdos.
curricular
Aí
studies
facilitou o nosso trabalho com o Ministério, que a
isn't
primeira
our
abordagem
work
foi
with the
apresentar este
ministry
projeto ao Ministério,
to
fomos bem
present
recebidos.
this project to
Criação de task
ministry, and they were
force
well
com
welcomed.
Organizações que implementam planeamento
Also
familiar
with
e apoio em
organizations
Moçambique,
that implement
algumas
these
organizações como
areas,
o IPAS, DKT,
some
a
organizations,
PAMO e a própria OMS, onde fizemos vários encontros para partilhar
several meetings
alguns achados das
to
visitas
discuss
que nós fizemos.
the findings
Porque neste
of all these
trabalho,
studies.
depois
This
visitamos
work,
várias instituições, selecionamos 3 instituições daqui de Moçambique, sendo
three
10 de nível
three
médio
institutions were
e 3
selected
universidades.
here in
Visitamos
Mozambique, 3
para fazer a
universities,
de base, ver como é que estão, como é que as instituições
to
implementam
analyze the
estes
basics
conteúdos nos seus currículos.
and also to see
Dentro de algumas
the enrollments of
constatações que nós
students
vimos
on
que
this
o país
subject.
tem um currículo
They realized
aprovado
that
pela
country
entidade reguladora, isto para a instituição
has
nível
this
médio, que é o Ministério,
as a
tem um
curriculum,
currículo,
and
todas as
it is
instituições nível médio usam este currículo, quer instituições
all,
privadas ou públicas, todas usam um currículo aprovado pelo
all,
Ministério.
all the
Enquanto as
institutions use this
universidades, cada
curriculum,
tem seu currículo,
either
não
public
tem
or
nenhuma
private.
uniformização do currículo entre
There's
estas
no
instituições de nível
uniformization of the
superior, eu falo de
curriculum.
universidades que formam médicos. Vimos também algumas
Universities that
constatações
form
que
doctors.
não há uma formação psicopedagógica regular
This
das
is not a
instituições.
psychopedagogic
Vimos também
training.
que os tutores que acompanham os estágios não
Also
têm
with the
treinamento
tutors, they are going to have
nesse
training
currículo
on this curricula
baseado em desempenho. Foram
based on their performance.
das constatações que nós
But one of the
vimos.
findings,
E traçamos algumas ações. Mas antes,
so
vale a pena
we traced
falar
some
dos
actions.
desafios que nós temos para trabalhar
First,
com
the
as
challenges that
instituições.
we're having,
Temos muita
working with
burocracia para ter
people,
acesso a alguns
a lot of
documentos, como
bureaucracy
agora
to
estamos
have
na fase
access.
de ver o currículo destas instituições e não tem
Now
sido
they're in the
fácil
stage of
termos acesso
analyzing
ao
the
currículo, mas
curriculums
aos
from the
poucos vamos começando
institutions,
estamos a ter, mas não é fácil. Outros
but it's
desafios
not
que nós
easy.
temos é a
Other
indisponibilidade do
challenges,
corpo docente para
it's
estarem
about
alinhados
the training,
conosco e
the
nos
professionals, the
explicarem
teachers,
rapidamente como é que é o trabalho
and
que
she's
eles
going
estão
to
a fazer.
explain
Então, dentro das
how's the work.
constatações que nós tivemos nas visitas,
Some
traçamos
findings
alguns
on the
planos de
visits,
ação
some action plans
para
were
ultrapassar estas questões.
presented to
Dividimos em fase. A
overrun
primeira
these
fase,
questions.
ou seja, a
So
ação
they divided in
imediata, que nós,
phases. The first stage,
sugerimos que deve
we
uma
suggested
atividade. Temos
that
primeiro
there
a
should be an
atividade para a
activity
uniformização do processo de formação quer nível
to
privado ou
uniform
nível público, ou
the
seja, o
training
currículo tem que
process.
ser implementado da mesma maneira
The
que
curricula
nível
has
de
to be
instituição, seja
implemented in the
privada ou
same way
pública. Temos
in
também
the private and public schools.
advocar nessas instituições para que haja
We have
limite de
to
número de
advocate in these
alunos
institutions
para a
to
formação, para as turmas.
according to the
Isto
number of
facilita a
students for the
aprendizagem. O
trainings.
currículo prevê 30, mas na prática
The
encontramos
curriculum
60, 40. Então, queremos
foresees 30, but in practice there are 40 or 50.
Vamos também advocar para que haja
They are
uma
going to
formação
advocate
psicopedagógica de forma
for a
regular para essas
psychopedagogical
instituições
training
para garantir que o currículo
for all these
baseado
people to
em
ensure
desempenho seja implementado na íntegra.
that
Isto são
all
ações imediatas e a médio prazo. Nós
the implementation
fizemos
of
algumas
these procedures.
atividades que é
Some
que
activities
o currículo implementado tenha mais
that
componente prática
are
em
going
relação à
the
teórica.
curriculum add a more
Nesta
practical
avaliação também
component,
vimos que não há muita
but in this
uniformização. Há instituições que têm
analysis
mais
we've seen
teoria
that
em
there's
relação à
no
prática.
uniformization,
E temos outra atividade que é
and there's another
influenciar, ou
activity
seja, criar
to
condições para que as
influence
instituições
and create conditions for the
passem a
institutions
usar docentes treinados nesta
to
metodologia.
use
E por
trainers that
fim,
are
como as
trained in
universidades
these
trabalham de
areas.
forma não alinhada com ao Ministério, vamos trabalhar de forma com as universidades para
They are going to work with
implementar um currículo
universities
baseado em
to find a
desempenho,
curriculum
treinar
that is based on the
docentes, alinharem
development
o currículo, pelo
to
menos no que
train
diz aos conteúdos.
teachers
Aqui
and
sabemos que é
to
difícil, se calhar, trabalhar no
uniformize
currículo, mas
curricula.
passamos a como somos uma associação de saúde
Uh,
técnica,
We are a
profissional,
technical
nós
association
estaremos
and
a
professional health
influenciar para que
association.
estas universidades passem
So
a
their
transmitir
aim
os
is that these
conhecimentos
universities
que
can
os
transmit the
obstetrícia
knowledge of the
alinhados
OBGYNs
com as normas do
that are
OMS,
aligned
nós
with the
iremos
norms of
trabalhar
the
nesse
OHM.
âmbito. E
OHM.
para a
Yes.
última fase,
The last stage,
que a longo prazo, no fim disto
in the long
tudo,
run,
esperamos
we are
advocar
hoping
para que o currículo de
to
formação,
advocate
quer a
that
nível
the
médio
trainees,
e as universidades, esteja
even
alinhado
medium and universities, are aligned
às normas da OMS
with the
e que
norms
todo
of
moçambicano
HM,
formado nessas instituições seja formado da
and
mesma forma.
everybody that is
Muito
trained
obrigada,
are
rapidamente isto se conclui.
have a uniformized training. Thank you
Respeitando
very
os
much.
minutos que me foram dados.
Thank
Thank you for
you.
the minutes.
Thank you to
Tentei ser breve.
Joanna. That's great. Well done also, Rita, our lovely translator, when technical difficulties arise. Bruna, can you just tell me if everyone can hear me? Because I know that
Tradução,
Joanna
não
can't
estou a
hear me.
ouvir. Por favor.
Yeah, it's working fine, Zab. Just carry on.
Okay. So thank you, Joanna, for that very practical example about getting different curricula into alignment with the WHO guidelines and global standards for family planning and comprehensive abortion care. It is no easy ask, especially when dealing with bureaucracy and dealing with public and private institutions. Thank you for your insights. And I would like to hand our mic over to Professor Goma Naraula, a midwife and president of the Midwifery Association of Nepal, who will give us some insight into the midwifery perspectives of implementing competency-based education in collaboration with our obstetrician and gynecology colleagues.
Thank you, Jeb.
Go.
And first of all, I would like to apologize for not able to visualize because of my internet issues. So
Oh, we can see you. We can see you.
yeah, but it is not, the internet is not so good, so I'm unable to visualize in video. Okay. Yeah. Thank you, Jeb, for this opportunity. Greetings to all of dignitaries. First of all, I would like to thank ICM and FIGO for the selection of my society from Nepal as a panelist on this vital event on the auspicious occasion of World Contraception Day. This collaborative for women and abortion contraceptive care together initiative brings together the FIGO and the ICM, and it was wonderful experience in Nairobi, and where we were able to learn from the different countries. And this type of collaboration is first time for the globally, and it helps for the implementation of best practice in family planning and comprehensive abortion care, and strengthen partnership to enhance quality care and improve health outcomes. In Nepal, there is a short history of midwifery. Midwifery education has been started in Nepal since 2016, and only 133 midwives are registered in Nepal Nursing Council, and currently 10 institutes are running midwifery program. We all know midwives are frontline for women's health. Family planning and comprehensive abortion care, post-abortion care service are care core midwives' role, as it is already mentioned in the ICM Essential Competencies Stone. It is also incorporated in our National Midwives scope of practice. Progress has made in education, but gaps are there, like inconsistent skills and supplies, weak interprofessional teamwork, no deployed graduate midwives as in professional midwives in a government health system, because midwives are not deployed, integrated in the health system till date. But in our midwifery curriculum, ICM essential competencies are included, and students are perfect in knowledge as teaching in classroom. But they have also opportunities to practice in simulation lab, but not more chance to practice in clinical setting because of not everywhere there is no midwifery model of care is implemented. As per our health system, midwives are not allowed to do practice of family planning and comprehensive abortion care practice unless and until they will get additional training from National Health Training Center. It means immediate after graduating from the midwifery course, they are not allowed to do practice of family planning and the abortion care services. But after getting the training from the National Health Training system, they are allowed to provide the abortion and the family planning services. We from the society struggling for the certification of family planning like IUCD and the implant during their graduation of midwifery course, because of the competencies are there as mentioned in the ICM essential competencies. There is huge gap in OBGYN midwives, especially in the private hospital, because the hierarchy is the very up and down, because the obstetricians are in the up rank and the midwives and the nurses are in the lower rank. So there is a huge gap. So need to organize, to address those gaps, we need to organize a joint program for collaboration, joint protocols to be developed to help the joint program and training and drills. It also helps for smooth referrals and shared responsibility if we are able to collaborate jointly with the OBGYN and the midwives. And so advocacy priorities are some of the points I mentioned here, some of the advocacy priorities as a recommendation, like authorization for full family planning, post-abortion care, and comprehensive abortion care scope. It should be authorized by the health system. And the investment in skills lab, in the pre-service education, if the midwives are competent, I think some of the family planning methods like oral contraceptives methods, condoms, they are allowed to provide without training by the National Health Training System. Only IUCD and the NERPLAN to introduce those type of contraceptives, they need to take that training from the National Health Training System. And it is also necessary to supportive supervision, including mentoring. Because in the pre-service education, all the midwives are will be able to competent in the pre-service education. So in service education, in service training and the coaching and the mentoring is mandatory to update their knowledge and skills to provide the quality care in the community. So
Madam Goma.
Yes, madam.
I'm sorry to interrupt you there, but if I summarize the journey that you are on in Nepal, I see very strong words about interprofessional collaboration and a very strong connection between what's happening in pre-service curricula and the in-service situation and how you can streamline things with the support of obstetricians. As you mentioned, the National Training Centre is an extra step for postgraduate midwives, and it would be great if they could get those family planning and comprehensive abortion care skills pre-service. Thank you so much for sharing some of the challenges, and I am sorry to cut you short. I'd like to hand over the microphone to the younger generation.
Thank you,
David Martin, you're welcome. David Martinez, you are here representing the International Federation of Medical Students Association, and you're going to represent the voice of what it's like for people coming from the school and the training institutions into our working environments. Go ahead.
Thank you. Thank you very much. Hello, everyone. Good morning, good afternoon, good evening. It's truly an honor to be here on behalf of medical students worldwide as part of the International Federation of Medical Students Association. So let me start by asking you a question about how do we ensure that all the work being done by FIGO, IACM, and other partners has a real impact in the next generation of healthcare providers? And also, how are we making sure that healthcare providers are aware of the urgent need to approach SRHR correctly with an interprofessional and multidisciplinary perspective? The answer is simple, considering that today's students will be the leaders and healthcare providers of tomorrow. So today I would like to share our perspective on two pillars that can transform women's health. The first one is about competency-based education in family planning and comprehensive abortion care. And the second one is about interprofessional collaboration between doctors, midwives, and students. So together, these two approaches can shape not only how we are trained, but ultimately how we care for women in the future. So starting with competency-based education ensures that future healthcare providers are not only we don't only have the knowledge, but we are also skilled, ethical, and confident in delivering patient-centered care. In family planning and comprehensive abortion care, this means being able to perform practical procedures, apply ethical decision-making frameworks, and approach patients with cultural sensitivity. Next slide, please. So to ground this, we conducted a survey among medical students worldwide about sexual and reproductive health education and how SRHR is integrated into the medical curricula. The results were striking. The results revealed significant gaps. For example, while topics like HIV and AIDS and maternal health had moderate coverage, critical areas such as access to safe abortion, gender-based violence, LGBT health, and care for transgender individuals were often missing entirely. Many students reported receiving no education at all on these issues. This lack of training leaves future doctors underprepared and directly impacts the quality and safety of care that women receive. I would like to mention that also in many situations and contexts, curricula are adopted and adapted to the recommendation and global standards. But however, the reality is often very, very different. They can be biased by the individuals delivering them, or there may be a lack of resource that prevents them from being properly implemented. So for that reason, IFMSA is helping, and we are trying our best to fill these gaps through workshops organized by students for students. Next slide, please. So addressing interprofessional collaboration, I would like to mention that education alone is not enough. Medical students recognize that improving women's health is a shared responsibility. When students learn alongside midwives and doctors in workshop or clinical rotations, we gain perspective and skills that cannot be learned from textbook alone. This collaboration fosters respect, strengthens teamwork, and prepares us for the reality of clinical practice. When competency-based education is combined with interprofessional collaboration, women benefit from more timely, safe, and respectful care. The result is tangible: reduced maternal morbidity and mortality, increased reproductive autonomy, and progress towards genuine health equity. Next slide, please. So in summary, medical students are committed to become a part of the solution by learning, collaborating, and leading with equity in mind. But we cannot do this alone. For that reason, we have a call to action. We call on educational institutions to integrate comprehensive sexual and reproductive health training into our medical curricula, healthcare system to standardize and integrate the creation of interdisciplinary teams, and to policymakers to meaningfully engage young voices in shaping the future of healthcare. For that reason, together, through competence education, collaborative practice, and youth participation, we can prepare the next generation of healthcare providers to deliver safe, effective, and equitable care for all women. Next slide, please. And this is my call to action. Let us work together across disciplines and generations to ensure that every woman receives the care she deserves. Thank you.
Thank you, David. I don't think I even need to summarize, because you had a great slide saying a summary of all of your intent, and it just shows real commitment from all levels of our professional cadres. So we are short on time, but we do have time left for our lovely Ulrika Renström-Loy, who is the Technical Officer for Midwifery at the WHO. You've got about 4 or 5 minutes, Ulrika. I'm very sorry. And I will just give some brief feedback about access to recordings and documents and the answering of questions after your presentation. And we'll probably finish at a couple of minutes over 5. So go ahead, Ulrika.
Thank you so much, Sab, and thank you to the previous speakers. I will link everything what they have said to some of WHO HRP's technical guidance documents. So next slide. So in 2022, you can take the next slide. Yeah, in 2022, WHO and HRP published the abortion care guideline with many recommendations. Clinical recommendation, health workforce recommendation, but also legal and policy recommendations. And this one provide really a comprehensive evidence-based recommendation to abortion care. And it has a very strong focus on rights-based approach, person-centered care, respectful care, and the goal is to support countries and member states to provide and deliver comprehensive abortion care that is safe, effective, and high quality. Next slide. Then 1 year later, we published the Clinical Practice Handbook that then again turned those recommendations into practical steps for healthcare workers. And after the clinical handbook, we also published competencies, 57 competencies that you have heard the previous speakers talk about. And you heard also our medical student, he was mentioning that in their curricula, there is lack of family planning and comprehensive abortion care modules. Students today, doctors, midwives, nurses, and other healthcare providers, they don't learn these competencies, these skills, knowledge, and attitudes to be able to provide quality of family planning and abortion care. Next slide. So what are then competencies? Maybe we have time to quickly look at this video, Sab, about what competencies are, because this is so important and this is what we have heard about. So I think it will be a nice end to and also a teaser for you that are listening to this webinar, that you can advocate in your countries to have competency-based education when it comes to family planning and comprehensive abortion care. Over to you, Bruna, to start the video.
WHO has developed a set of global competencies for the provision of family planning and comprehensive abortion care to ensure the same high standards of care for everyone. The competencies contain the knowledge, skills and attitudes you need to perform quality care and set a global benchmark that will guide education, training, performance reviews, service delivery, and policy decisions. The competencies can be used by all of us who work in family planning and abortion care, from community health workers to specialist physicians. How can you use the competencies in your work? If you're teaching, you can use them to design your course, since the competencies provide the learning objectives and the outcomes that need to be assessed. The competencies provide a roadmap for the course so that you and your students can both assess how well they're progressing. These competencies will help students manage their own learning by showing what they need to learn, letting them reflect on their progress, and helping them easily see what needs to be achieved. The competencies have been designed to help every profession whose duties include some aspects of family planning and abortion care. While you may not use all of the competencies, many of them will be applicable and can be utilized for in-service training. They can help you identify gaps in capability and take steps to develop any competencies which aren't at the required level. By specifying acceptable standards to protect your clients, you can lead your team with confidence and provide an internationally recognized quality of care. As a policymaker, these competencies outline the criteria that providers need to meet in order to create up-to-date, evidence-based practices and responsibilities that meet the international standards of care. These competencies are relevant to everyone involved in family planning and abortion care services and contain vital information defining the attitudes, knowledge, and skills that are needed. By using them, you and your team can ensure that family planning and abortion care is always provided respectfully, effectively, and based on best practices.
Thank you so much, Sab. Over to you.
A great film. Okay, so we haven't got time left, unfortunately, to address each of your questions individually, but I have got a little bit of a wrap up, okay? A recording will be made available on both the FIGO and ICM websites. After we have closed the webinar, we will circulate a survey link. When you complete the survey, this will trigger the generation of a certificate. And this works even if you watch the recorded webinar, okay? We will also be sharing links to the WHO and ICM competencies. I am guessing that my fantastic colleagues have already put these in the chat. Just a wrap up of a few of the questions that came through, rather than answering them, I will give you a few well-directed pointers, things that we have learned in the conversations that we've been having as a team as part of the C4W initiative when it comes to legality issues around safe abortion, where safe induced abortion at the mother's request is not available, but midwives and doctors are still dealing with the complications of unsafe abortion. We must always remember that we address post-abortion care as a very important part of comprehensive abortion care, and it is in fact a human right. And in the WHO guidelines, there is a very good section on addressing the needs of the population when you are only able to do post-abortion care after unsafe abortion. We also have to remember about the importance of advocacy for addressing misconceptions amongst women and their partners, families, and communities, so that we do not restrict women's access to contraceptives by failing to address fear and myths and misconceptions. It's so important to advocate direct to women, and our women's advocacy partners are the best people to help us with that. So thank you everybody for attending. We're about 4 to 5 minutes over schedule, and we are so pleased that you stayed with us. I can see almost everybody is still with us. And really now I will say thank you to all of our speakers and interpreters and participants, and close for today.
Thank you.